Well, good morning, everyone. I can't see you, but I think my picture's up on the top there someplace, and you can see me. My name is Tom Ollendick. As indicated here, I'm the director of the Child Study Center at Virginia Tech, Department of Psychology. I'm also been involved in many national and international groups, and I lecture throughout the world, including South America, Australia, Asia, Europe, all over literally. But I am trying to do things here at Virginia Tech, which are trying to look at whether or not we can alter the current path of how we do psychotherapy with children and adolescents and their families. I don't know how many of you are psychiatrists or psychologists, or how many of you are pediatricians and other medical personnel. But as you probably full well know, the convention is to see a child, a family, for 50 minutes a week, and then to do that for X number of weeks. That's how long it takes. What we are trying to do are what are called brief intensive treatments, and we're really trying to turn that on its head. That is, we're suggesting you don't need to do that you can provide very, very effective therapy in a much briefer period of time. I'll try to illustrate that this morning. So I'm going to go through a few slides, and if you have comments or questions, please let me know. At the end, I will have some multiple guess, or choice, I should say. Guess, choice, questions. My students up here call them multiple guess, but I think there'll be multiple choice for you folks. So I will get underway. And again, if you have comments and wish me to slow down or speed up or do something else, let me know and I'll try to do it. Thanks again for having me. So here we go. This is Virginia Tech. Those of you who haven't been up here, I invite you to come up. These pictures were taken by last spring by me. Not this spring, as you might imagine. Those things out in the middle, that picture in the middle, are called students. And we have a duck pond, a little lake on campus, and flowering trees, etc. It's a beautiful campus, and I invite you to come to see us sometime. I am at the Child Study Center, as I mentioned. It's primarily a research, training, and service clinic. We have people coming from all over the United States for our services, which I'll show you in a few minutes. That's some of the things. Today, I'm going to be talking primarily about anxiety and phobias in children. Hence, we have here several people, several families who've been involved in our treatments with their permission to use their photos, and also some of the students working here with us. We do work on phobias, on autism, on social anxiety disorder, on panic, and we're now doing stuff on COVID-19 and how anxiety is being produced by that. Now, as you might know, anxiety in children and adolescents is very prevalent. Down at the bottom of this slide, you can see that collapsed across all the disorders. It's 28.8%, almost 30%. That's almost 1 in 3 children and adolescents will have an anxiety disorder by the time they reach 18. Now, this is really important for you folks over there because oftentimes these anxiety disorders go unrecognized. And there's some very effective screening tools that can be used to identify whether or not any of these problems may be present or not. You can see up at the top that specific phobias are the most prevalent of these disorders, followed by social phobia, on down. Now, admittedly, in this slide, both obsessive compulsive disorder, toward the middle there, and panic disorder are also listed for anxiety disorders. They now in DSM, as you probably know, are no longer categorized as an anxiety disorder. But even if you take those out, it's still around 27%. Because of the overlap of disorders that occur. It's very common to have more than one of these at a time. This shows you the cumulative prevalence of these disorders. Now, again, if you look up over on the left-hand side, cumulative percent on the bottom, age from 4 years on up to 18 years of age. And you can see the red line at top. The red line at top is illustrating the anxiety disorders. And up at the top, you'll see that by the time of age 18, it's around 30%. 30%. And again, very, very high. Behavior disorders like ADHD, oppositional disorder, conduct disorder, all are increasing. They're ending up at around 18%. But then what you also see is that depression, very commonly co-occurring with anxiety, it tends to pick up with adolescents and then escalates pretty rapidly on into up age 18, where around 14.7%, I think it is exactly, of adolescents will have a depressive disorder. And again, as you get into adolescence, of course, you can see the bottom line, substance abuse, picks up around 13 years of age, and then just climbs like stair steps going up to, again, around 20-some%. So you see, these problems are very common. Look at those for a moment over on the right-hand side under age 18. You'll see that anxiety is very high, phobias are high, behavior problems are high, depression's high, and so is substance abuse. So these people we work with, these children and adolescents, are very, very prone to these disorders. And as a result, they're very common, we observe. Now, I'm going to talk today a little bit about phobias. Why phobias? Well, I'll try to explain that to you as we go through this. First of all, some of you may well have a phobia. It certainly would not be uncommon. If around that many adolescents have it, you can see that probably around 15 to 20% of adults, and that means 1 out of every 5 of you probably has a phobia. And it can vary from whatever it is, whatever it might be, from snakes to spiders to airplanes to heights to vomiting to blood injection to whatever it might be. But in any event, you can see here that in adulthood, in this sample of Gregory et al., the mean age was 32 years. And when you have a phobia at that age, it's oftentimes preceded by a phobia in childhood at around 9 or 10 years of age. Than any other disorder. Other anxiety and mood disorders in adults are also more frequently preceded by specific phobia than any other child disorder. And only 8% of those with a specific phobia reported receiving treatment of the disorder. Now, that to me is just inexcusable. 8%, less than 1 in 10, are being treated for these phobias, which, as I will conclude on the bottom part of this slide, that phobias are a gateway disorder. They're a gateway disorder, meaning that they are the gateway to some of these other problems that happen. And we can treat them. We can treat them very effectively. And so as a result of that, the prevention and treatment of juvenile phobias represents a major health imperative. And I think we simply need to move in that direction. Now, as you all might know, phobias are, like anything, are multiply determined. And there are many different factors that can lead to a phobic and anxiety disorder, from genetic factors. If you have a parent who's anxious, the probability of having a child who's anxious is enhanced. Temperament, behavioral inhibition, attachment, poor attachment, parental disorder, parental practices, learning, information biases, peer relationships, neuropsych and neurobiological. All of these, that's 10 different possibilities here, and there are many more. There are many more that could occur that can lead to these phobias and anxiety. We'll try to talk about that as we proceed. I'm going to give you a couple of examples. The case of behavioral inhibition. If I'm doing this live, I usually ask how many of you have children? And perhaps at your ages, maybe many of you would raise your hand. I'm not sure. I have 2 daughters. I have 6 grandchildren, to be honest with you. So I do have them too. One of our daughters, our older one, was more outgoing. And the second daughter, Kate, was a little bit more inhibited and shy. But in any event, we know from Jerry Kagan's work up at Harvard that about 10 to 15% of children will be behaviorally inhibited. That's a temperament. It's the way you are born. It's a biological factor. It's to some extent genetic, but not totally, because temperament can be influenced by the condition of the mother during the pregnancy. A certain drug abuse, for example, or alcohol, or certain stress and anxiety can all lead to a temperament that leads this way. But you can see here a couple pictures of kids who have this. Now, what we know about behavioral inhibition studied over the years, this temperament, is that kids are irritable and reactive. You see these in your practice, I assume. Toddlers can become shy and fearful and very inhibited. Wary to meet you, and especially to kind of cower behind their parents, perhaps, and look up at you. Phobias, when they become more 3-4 years of age, separation anxiety, and on down into adolescence, which phobias, social anxiety, generalized anxiety, panic, and depression. And those are also present in adults, by the way, who tend to not be treated. Now, one thing I should add is that because you're born behaviorally inhibited does not mean you're always going to stay that way. We can change that. We actually did a study up at Harvard, I did, with some colleagues there, where we looked at whether or not we could change the temperament, and we could. We could change the temperament by the way in which we had parents interact with their child, because you see, the child presents the stimulus. Don't make me do anything. I'm shy. But if the parent can encourage that, you see, that can then lead to advancement. So you can change this. Parental influences, overprotection. Some of you know the cartoon Pearls Before Swine, I assume. What are you doing? I'm researching trips to the South Pole. Thinking about visiting my pal Ole, the penguin. He's the one with the overprotective mom. But all those penguins look alike. How would you ever find him? I ask you to look at the third panel on the right-hand side. You identify the behaviorally inhibited and the overprotective penguin. Brackman, and who's up at British Columbia and was over in London, and myself and colleagues in Australia have talked about three different pathways to learning, how that can be causal. It's direct conditioning. I'm sure you're all familiar with that. Pavlov's early work was direct conditioning. Vicarious learning, you can just observe and see things. And negative information, be told things. And that's what happens with a lot of children. They're told things that a spider can do this. A spider can crawl up your arm. It can and go on your face, or a snake can come up and bite you. They're told things like that, either through stories they read, or parents, sometimes, not always, but peers, and others who can pass that information along. Here's a girl we treated who actually was, well, no, I can't say where she's from because that would be disclosing too much information, but she was bit by a dog. This is her face. And this is when we're doing treatment with her. This is her face. She was severely injured by a dog bite, a major dog bite, as you can see here. That's direct conditioning. Now, if you had that happen to you, I would bet anything that you too are going to develop a wariness, maybe even a fear, maybe even a phobia of dogs, at least certain kinds of dogs that might be related to that. So you see, it's very, very possible there are these very direct conditions. But before I leave that, I just want to quickly add, sorry, I'm rushing through this, but I'm trying to do this. I sometimes do 1, 2, 3 whole week workshops on these topics. But here I'm doing it in 50 minutes. But here, you see, not everyone who has a fear is directly conditioned. And that's got to be very clear. Only about 10 to 15% of phobias or anxiety disorders are related to direct conditioning. Most of it is indirect through observation and or information that we get. Now, I'm what we call a developmental psychopathologist. What that means, these two terms, equifinality and multifinality, it means that any one given outcome might result from multiple and different pathways, diverse pathways. So an anxiety disorder or a phobia can result from different, multiple, and diverse pathways. So some will be genetic, some will be biological, some will be learning, some will be environmental, some will be cultural. There could be a variety of factors that come together. And of course, not uncommonly, many children have multiple. There's more than one. This is a diversity of things that come together and congeal on this child. More important too, or equally important, actually not more important, but equally important, multifinality. Point B, any one cause or pathway can result in multiple and diverse outcomes. Now, many of you, I am sure, have heard of the World Trade Towers, 2001, 9/11, and all of that. At that time, 2001, I was at Virginia Tech. I came here in 1980, by the way, so I've been here 40 years now. But at that time, I was on a panel of people working in New York City with families who had been affected by the World Trade Towers. Well, one family I worked with, I should say, I didn't work with literally, I consulted with them and advised them how to work with this family, had 3 children. The father goes to work and is killed. Now, put yourself in this situation. Take yourself back a year or two, or maybe 10 or 20 or 30 or 40, when you were a child, and ask yourself, what would you have done had your father been killed? Actually, at Virginia Tech in 2007, you might remember that, the shootings up here, I dealt with several children of professors, a woman professor whose children, a woman died in that shooting, very similar. But my main point here is that there were different outcomes. One cause, the World Trade Towers, shootings at Virginia Tech, one pathway can result in multiple results. What do I mean by that? Well, this one family in New York had 3 children, had a 13-year-old daughter, a 10-year-old, 11-year-old son, I'm trying to remember now, and a 9-year-old son. So 13, 11, yeah. And the oldest child had developed extreme oppositional behavior. She was just very angry at stuff that had happened, and so angry at everyone in the world as to what had occurred. And she became very oppositional and started to really do negative things. The middle child, on the other hand, seemed to develop a phobia. He did develop a phobia. He developed a phobia of loud noises and airplanes and elevators. Now, why? Because as you know, if you've remembered that well enough, 20 years ago almost, gosh, that's impossible, but it has been. But if you remember that well enough, you know that people were killed in elevators, went up, down, caught in the elevators, airplanes coming in, et cetera, et cetera. Airplanes, We dealt here at Virginia Tech, not only up in New York City, but here at Blacksburg, Virginia. And Roanoke, by the way, we served the Roanoke area as well at times. But my point here is that we had people who came in to see us because of loud noises or because of can't being able to fly in an airplane. They can't, the parents go on a vacation, they can't go up on the elevator when you're in a hotel room. Well, that's okay if it's only 2 or 3 stories, but if you get outside of our community, Roanoke area, New River Valley area, you get into some places that have more than 3 stories or more than 5 stories. They have like 35 stories. And you start to walk up all those stairs, you know, it's a long way. And that's going to cause a problem if you can't get in the elevator. Main point here, take home point, is that any one outcome can result from multiple causes, and any one cause can result in multiple outcomes, diverse outcomes. I hope that makes sense to you. I wish I could see your faces and see if you're agreeing with me or disagreeing with me or whatever, but I can't. So now I'm going to tell you about some things that in treating phobic and anxiety disorders, the way that what the literature looks like and why we moved in the direction we moved in. Several what are called meta-analyses. I don't need to get into those here, but the main point here is that cognitive behavior therapy has been shown, in contrast to almost all other therapies, but certainly CBT is in the foreground of the relatively well-established, in fact, they are now called well-established, the treatment of choice. That if you have children who have anxiety and phobias, they should be being referred to people who do cognitive behavioral work if you want them to receive the evidence-based interventions that are there. Now, there are other ones that are being worked on at this time, but at this stage, these are the only ones that have been worked with and good. Down at the bottom, where you'll see that several different reviews by myself and former students, Amy Grills, now up at Boston University, and Laura Farrell in Australia, and Peter Merth in the Netherlands. We've done this work on reviews of this literature. It's very compelling. It's very compelling. It's evidence-based treatment. And that's what we need to be about is how to provide that for children. Now, what I want to now turn to is what those evidence-based treatments that I just referred to have been more traditional, if you will, that they've been 8 to 16 sessions, outpatient for the most part, and they have been delivered on a weekly basis for the most part. And for the most part, they're like 40 to 50 minutes, maybe an hour long. So these are standard treatments. Well, what is becoming more clear now in recent years, last 10 to 15 years, I would suggest, is that there are what are called these brief low-intensity interventions. And there are also brief high-intensity points 1 and 2. Low intensity are things like bibliotherapy, self-help, internet programs, which are really becoming popular now, of course, with the virus. 30-minute advice clinics in your offices. There's actually some studies that show that when you give, or you have a therapist in your office with you, some places have that. I know we've had it up here, where you can be there and the medical doc refers the family to you, and you then talk with them for 25, 30 minutes. And you give them some good advice on how to proceed. And for a lot of people, up to 30%, or maybe as high as 35% of children and adolescents who are anxious and phobic can be helped with that, because there's some things that you can tell them, educate them. We have written 3 books, well, I've written 38 books, but 3 of them are bibliotherapy books in which we wrote them for parents to read to their children. Phobias of dogs, phobias of the dark, for example, in which we're treating that, and we published on these things, and they work for about 40% of the kids, 35 to 40%. They don't work for all. But that's where you then need to move to another level of brief high intensity interventions. What we do there, and what we've talked about, is the modification of more traditional CBT approaches by reducing either the number of sessions, like going from 16 to 1, I'm going to tell you about 1 session in just a few minutes, to doing it. We have people coming down from New York City, again, in LA actually, being treated for OCD here in a 1-week program. So they come down for 1 week, and we do treatment with them for 5 days, morning and afternoon. And it works as well, if not better than the traditional outpatient therapy. So in other words, what we're doing is trying to turn therapy on its head and trying to look at it from a different angle. What can we do as well or better if we do things this way? This is a paradigm shift. Paradigm shift just simply means you're doing things differently. Therapy is delivered outside the typical therapy in fewer than 9 to 16 sessions. I call this CBT Strong. Now, I don't know about you folks, but I occasionally in my weaker moments have a beer. Actually, on many moments I have a glass of wine, a glass of a Cabernet, by the way. But in any event, they're CBT beer lights and they're beer strongs. And CBT light is like a light beer, if you will. Sorry for the analogy, but it usually works with people. And CBT strong, which is a heavy, robust beer, but it's also a heavy way of doing CBT. Now, why do CBT strong? Again, I wish I had more time here, but basically, CBT strong, this brief, intensive treatment, it involves the two primary components of traditional standard CBT. CBT, cognitive behavior therapy, cognitive challenges, behavior exposure, graduated exposure. Now, I'm not sure about you folks, but I hearken back. I was born in Nebraska, grew up in Iowa, the Midwest, and I remember my grandmother saying once to me, Tommy, just get back on the horse. Get back on the horse. The horse threw me off. I had a horse named Lady, by the way, and she was not a lady at all times. She threw me off. I fell off, probably more truthfully. But the main point is that she said, even my grandmother, this is in a few years ago. I won't tell you how old I am. But in any event, she just said, get back on the horse. That's the treatment. And she was right. She was right on, spot on, that you got to get back to exposure. So what happens in most psychotherapy is that you just talk about things. You talk. I, by the way, was trained psychodynamically. I'm not sure how many of you know, this is a Sigmund Freud-like approach. It's not psychoanalysis, classic psychoanalysis, but it's psychodynamic. And I was doing therapy for a year, 2 years, once a week, 50 minutes, for 2 to 3 years with kids. And they just weren't changing. And so I thought, there's got to be a better way to do this. So again, I started to look into the learning theory and cognitive behavior theory to see if we could change that, and we did. But as you can see here, if you are scanning this slide, you have to read all this or remember, you're not going to be tested on the slide. But basically, what you're trying to do is give the child new experiences that will help with some new pairings of what they thought would happen. I wish I could show you videotapes and all of that, but you really have to see this when you see children who can't even go into a room where there's a dog. It has to be showing pictures from YouTube and things like that. But at the end of treatment is petting the dog, is leading the dog, is feeding the dog. Children with spiders will have spiders on each hand, and they'll be crawling in their hands, and they're letting them there, and they watch them move. Now, have you ever thought, by the way, of why a snake moves the way it moves? Why a snake moves the way it moves? It kind of undulates, doesn't it? It crawls like that. Well, you know, a very powerful lesson, and that, by the way, is one of the biggest things that children are afraid of about snakes, is that the way they move. They don't move like us. Well, you know, think of it for a moment. Think of it. Do they have legs? Not like we have. Do they have arms? No, not like us, right? They have to move by moving their body. So what I do in treatment is have them get on the floor. I get on the floor, have them get on the floor, and I model them. I'm going to go from here to there, 10 feet away, without any arms or legs. How am I going to do it? I move my body like that, right? And I look like a snake. I'm crawling like a snake on the floor. I even have a sport coat on sometimes. I do today, but I don't always. But the point being is that you have to model and expose to these things. Spiders too. If there were a spider wherever you're sitting and on your desk or whatever, and I've asked you to point your finger at the spider, have you predict for me what's going to happen? Spider phobic people will say the spider's going to run at my finger and crawl up my hand. And then you know what? It's going to crawl up my arm and it's going to come up on my shoulder. And I'm going to scream, ah! It's going to jump in my mouth. I've actually had that said to me by several children. The spider's going to crawl up my arm and jump in my mouth. Not likely. Not likely. In fact, I can show you trial after trial after trial, sticking your finger out at a spider, it's going to run away. It'll do the same thing you would do if you were being approached by someone with a finger sticking out and coming to aggress upon you. And so the spider runs just as you would run. The point being is that there's oftentimes, this is all part of what we do in psychoeducation, is trying to help people understand why things work the way they work. When you understand that, that's less fearful, because fear, you see, is oftentimes out of incomplete information. Sometimes it is complete. Like dogs can bite, snakes can bite, airplanes can fall out of the sky, you can fall from a ladder, you can get a blood injection shot and you can have a negative reaction to it. All these things can happen, but the probability of them happening is very small. Treat them like my grandmother did. Get them back in the situation. Well, Michelle Krask out of UCLA, Bolton at Denver, all these people suggest that you can do these things in this truncated way. Well, I'm going to tell you just very briefly about 3 recent studies we've completed. 3 NIMH, as you can see at the top, funded one-session treatments. I'll tell you what that is in a moment. And studies published in 2009, 15, and 18. And for $3.7 million, by the way, that we've been funded. We've been over 10 million altogether, 11 million altogether, but 3.7 for these 3 trials here. Comparing it to a placebo, education support, to a wait list, to 2 variations, a standard and a parent control, and then have phobias will travel. I'll tell you about that in a moment. The 3 different trials here. Now, this have phobias will travel is interesting. I'm not sure if you can see that very clearly, but you can see there that people have come down from Boston, and they've come down from Syracuse, New York, New York City itself, of course, DC, Virginia Beach, Wilmington, down to Atlanta, Memphis, Chicago. I guess they're not, oh yeah, Naperville, that's the Chicago one, Indianapolis, Columbus, Ohio. You can see that people come, they travel here for this treatment because it's one of the few places they can get it. So we've titled this article, Have Phobias Will Travel. I'm not sure about you folks, if any of you are approaching my vintage or not, but I remember a TV program, Have a Gun Will Travel, and that's what resonated to me about, have phobias will travel. People will come. If you build it, they will come. The baseball story told us that, didn't it? You build it, they'll come. And we have people coming for these treatments from across the U.S. We've actually had people coming from Ireland, from Japan, from other countries as well. But here's just the people from the U.S. But they come for this treatment because it's effective. And they'll go back and tell people about it. Now, what is one-session treatment? Wow, it's done in 3 hours, in the morning or the afternoon. So it's not 50 minutes. It's not once a week. It's once a week for 3 hours. It's an intense, really delivered treatment in which they come and are treated within those 3 hours. We use psychoeducation, as I said, graduated modeling, in vivo exposures, modeling, cognitive instruction and challenges and reinforcement. So we use all the cognitive behavioral principles, but we just put them into this cup, if you will, this cup that now has all of the therapeutic elements all in one condensed, intensive, brief treatment. Therapist meets with the child for about 45 minutes, about an hour, before treatment to do an assessment, basically, behavior analysis. Treatment is done during one morning or afternoon, 3 hours. The people who come to us, by the way, from different parts of the U.S., they come typically on a Thursday, and we might do this session on Thursday afternoon, this 1 hour meeting, 45 minutes. We do that so we can prepare ourselves the next day for whatever we need. We need to get snakes, we get 3 snakes. We need a dog. We have lots of people in our community who volunteer for us to use their stimuli, their dogs, their snakes, their whatever. We can go to their places, we can go to their building to have people go up an elevator, for example. People have entrusted us with that. And then we then pursue the students for these trials I'm talking about, we're all students at Virginia Tech. Here's a tarantula on my shoulder. It's not going to jump in my mouth. But basically, the guiding principle here for this treatment is that the child's cognitions, the fearful cognitions, about what might happen, they maintain the focus. So imagine that little girl who was bit by the dog. You go back to that for just a moment and say, gosh, what do you think is going to happen if she sees another dog? Well, she thinks that it could bite her again. If you think this one's going to jump in your mouth, if you think you're going to fall by simply going on a building or over by the edge of something, then your behavior is understandable, right? It maintains the phobic response. It's negatively reinforced, as we know in our learning theory work. But basically, it's perpetuated as a result of that. The exposure then is set up as a set of behavioral tests in which the cognitions are challenged. So we simply ask them to think about what would happen, and then expose them, and they let us know whether or not they really did get bitten or not. Of course, they don't do that in our treatment. They don't get bitten, that is. Nor do they fall. So you demonstrate what's going to happen. Guides, approximate physical contact. We'll have which you could see me, but we'll have our hand on the child's shoulder, like we're going to pet a dog, for example. This is not as illustrated. Then we'll move our hand down their arm and then down to their wrist and then down to their hand. And we'll put our hand and then their hand on the dog, and within an hour, we'll have them petting a dog. You know, they're phobic of dogs. Within an hour. We'll do 3 dogs. We'll do 3 heights. We'll do 3 snakes. We'll do 3 airplanes. We'll do whatever it takes. Because we want them to generalize. It's not just that dog. It's these dogs, you know, these spiders, etc. The child then does it. And what we're trying to do at that bottom cue there, which I think is really important, many of you may not be aware of Albert Bandura, but he's an extremely famous psychologist from Stanford who talks about social learning theory. And I'm a Bandura protege. And this notion of I can do it is extremely important, that I can get on that horse. I can lead this dog. I can climb that. I can have a blood shot. I can eat without vomiting. So basically the idea is to make sure that that can happen. A couple of illustrations, looking at the time here. Here's a 14-year-old boy who's afraid of heights. This is our center, this side of it. So we have these ladders and things like that where they'll go up and look off. Here is a young boy with a dog and his mom there with him. One of the therapists in the background, Maria. But you can see mom here. Mom, I love this photo because the boy is right there with the dog. And you probably, I don't know if you see him well enough, but he's looking very carefully at the dog. Look at where, well, I can see that his eyes are looking down toward the head of the dog. He was not bitten by a dog, but he was knocked down by some dogs in the neighborhood and was attacked, but never really bitten, just kind of brawled over, not mauled, but brawled. And mom, it turns out, also had a phobia of dogs. So now look at her back behind him. So he had an experience. Mom's a little reluctant to be involved with dogs. And I don't know about you guys, but if you don't want to get your hands involved in something, what do you do with them? Well, if you're doing something appropriate, stick them in your pockets. Okay? Because then they can't be out there. They can't be touched. They can't be touching or touched. Maria in the background is there kind of watching and guiding them on what to do. So you see, this is really, I think, an important example too. Here's a little girl, 7-year-old, afraid of worms. She couldn't go outside. She could not go outside. This goes, well, no, I can't really say again where she's from your neighborhood. But in any event, here she is in treatment. We have night crawlers. And you see them during treatment. She's getting them out of the little container. And then she's getting them on her wrist there, as you can see. She's kind of showing us what she can do. And we have the children, we take photos of them with their permission, the parents, and we send them to the grandparents and parents because they can show what they now can do. But she couldn't go outside when it was, well, she could go to school when it wasn't raining. It was raining, she couldn't go outside. She could not go outside because, I think in Roanoke as well as here, similar, that the worms come out, especially when it rains. And they come to the surface and you need to walk by them. So that was a little bit. This was a young boy we treated. He was from Pittsburgh, I think, if I recall right. But this is a boy who had a phobia of costume characters. So he's down in Disney World here. This is almost 3 years ago now, I think it was. And thank you so much for getting Kyle over his fear of mascots and characters. You have truly transformed his life, but you have also greatly improved the quality of our lives. We would never have guessed that within weeks of working with your incredible staff, he would be freely interacting with the mascots we visited as follow-up. So it's thought they do some continued exposure. Incredibly, we just returned from Disney World. You allowed him to reach his long-term goal. Your work is amazing. Now, Kyle wins, mascots lose. I love it. Now, of course, not everyone responds this way, but I want to show you a couple of success stories. Here's one. I was over in Oviedo, Spain last October, November, I guess it was here. Yeah, November 11. And this is a email message I received. Wow, let's get ready to give a closing address for a conference. Hi, Dr. Ollendick. I had to share one of the best days of my life. Today, I came home from work to be greeted by my daughter. She was so excited to tell me that she was no longer afraid of dogs. I cried. Today, she went to a friend's house that she knew had 2 dogs. She said she went inside. They jumped on her, but after a few minutes, they became calm, and she pet them. OMG, oh my God, my daughter pet a dog, a live one at that. I would never see the day that she would be okay to be in a house of dogs. I truly believe that if we hadn't been part of your research program and received the treatment program, she wouldn't have ever been cured. Amazing news. Thank you for accepting her into the program that proved your treatment of phobia works. Well, these are just some good examples, and these are, I know you all do the same thing. I hope you do at least. You keep these little records. This one was just last year. As you can see, November 11 of 19, that this one came into me. Now, collapsed across these many studies here, just briefly, showing these numbers probably are not meaningful. But basically, a 4 is a clinical diagnosis on a 0 to 8 scale with this diagnostic interview we use. And you can see that the red line is the one session treatment, the bottom one, and they drop off. They stay off 6 months. The wait list, hardly anyone improves. They don't get better. People always thought that phobias will just disappear. Let them go. They'll take it, but they don't. They persist. And then our placebo treatment does come down, but you can see that the average person is still in the phobic sample. Now, here's one thing I want to caution on, though. One of the caveats, I guess, is that if your child also has ADHD and a phobia and perhaps other things, but here I'm just looking at ADHD in one of my students from Iceland, Hildur Halldur's daughter from Iceland, and I did this study in which we look at if you have ADHD, how well do you respond? Well, you can see here, I hope that I don't know if that's clear enough in your slide presentation or not, but the top line are those with high ADHD symptoms, meaning they're clearly clinically diagnosed. And you can see that this is over 4 years, by the way. These numbers at the bottom, 0, 365 days, 2 years, 3 years, and 4 years, 1,460 days. So 4 years later, you see that they do get better, but look at the person with ADHD, how even out at 1 year, 365 days, they're still clinical, and in between 1 year and 1 year and 2 years, they're just starting to get down, but they don't really drop off until 3 to 4 years later. But those who do not have ADHD get better right away, the bottom line, basically. So you see there are some things that qualify, or what we call moderate or predict our treatment outcome. That's one of them. If you have ADHD, you want to be ready for that, because you see, think of it for a moment. If you have ADHD and I have you come in and I work with you for 3 hours, and you have ADHD, and you have trouble paying attention, and you're a bit hyperactive, guess what happens? You're not attending as much. You're not absorbing as much, benefiting as much from the exposure and the cognitive challenges that we're trying to do. So we're trying to look at that now as how we can modify that some more. Now, I want to turn quickly to autism spectrum disorder, because this is an area that we're working in now, which is very under-researched in terms of treating children with ASD and who have phobias. So we've been doing this for several years now, actually 5-10 years, I guess. But what is autism spectrum disorder? I know you all know this. It's difficulties in social interaction, those restricted and repetitive behaviors, and sensory sensitivity. And the prevalence of sleep phobias in children with ASD is estimated to be 30%. 30%, with up to, some studies up to 50%, showing that ASD kids do have phobias. Moreover, work we've done here with colleagues Susan White and Larry Scahill at Yale and Donald Oswald down at VCU in Richmond, prevalence of phobia, up to 84% of children with ASD experience significant one anxiety disorder or another. So phobias, it's only around 50%, 30 to 50%, but other anxiety is very high, very high. It's the most common co-occurring disorder in ASD, the most common co-occurring disorder. It's really important that we begin to look at that. And I know in my early days, we never talked about ASD kids having anxiety. Of course, back in my day, they were all largely nonverbal and intellectually deficient, if you will, children, delayed at least. And they just were not here. I can remember being in Philadelphia at a unit I was working with, and the average kid was between 4 and 6 years of age, but they were banging their heads and they were biting themselves and they were grunting and stuff like that. We never thought of anxiety as being the issue, but it could have been. It could have been anxiety that's driving some of these behaviors. Well, and what I'm suggesting down below there is why the high prevalence. And I think it's because we think, not just me, but myself and my team, I think it's the sensory sensitivities and fear conditioning. Sensory sensitivities. Think of that for a moment. If you're sensitive to certain sensations, like sounds, for example, loud bus driving by, a phone, a fire alarm at school, parades where they might have fireworks and things like that. It's just amazing how many of those kids who can't go to the Virginia Tech football, of course I can't either now, but can't go to Virginia Tech football games, either because they're characters like clowns or because of the noise. They're too sensitive to them. But those sensory sensitivities are real, and oftentimes they do result in fear conditioning. So the point there is that if you have I'm going to call it a predisposition, a sensitivity to fear of some stimulus, then it's more likely you're going to be conditioned to that than otherwise. So it still takes sensitivity, the more biological part, and the conditioning part, the more environmental or learning part, coming together. Environment and nature, nurture, nature, those kinds of things coming together again to produce the response that we're starting to see. So very, very possible that this is one of the reasons for that. We wrote a paper on this, by the way, that just came out last year. A brief review of that, we do conclude that sensory sensors are quite common. This is a study we just published, augmented one-session treatment for specific phobia in youth, using what's called a multiple baseline design. I'll illustrate that in a moment. But basically what we're doing is comparing our standard on the left-hand side to our modified for the treatment of phobias in children with autism spectrum disorder. Now, our standard treatment is 3 hours with the child, as I've explained. There's limited parent involvement, about half an hour. They come in and we try to show them what we've done and train them a little bit. Then we do weekly, 4 weeks, phone calls to kind of just check on their progress. So it's brief. They're usually 15 minutes, 10 minutes, maybe 18 sometimes, but average 15 minutes. And we remind them on the reinforcements of engaging and to encourage them. We also, by the way, it's an important thing, and when you work with parents, is oftentimes you work with a child, but who reinforces the parent? Who reinforces the reinforcer, if you will? So the parents are really busting their legs and their arms and everything to help this child out. But who's reinforcing them? Who's sharing them? So we try to set up a program to reinforce the parents. It is hard work. Now, our experimental treatment, if you will, is on the right-hand side. So we do a 3-hour treatment, just like we did over on the left-hand side. There's greater parent involvement, almost the entire session, 2.5 hours. The first half hour is spent in like education, so that's why it's not 3 hours, but it's 2.5 hours. Then we have them come back to our clinic here at Virginia Tech, and we have them come in for 1 hour in clinic. Now we're trying to do this online, so we're trying to work all of this out. But in this study that I'm going to show with you that's just been published, we had them come back into our office for 1 booster session. So basically all we do is have them come back and we have them continue the work that they were doing before. Only now it's for 1 hour, not 3. And they're showing us what they can do and they get more practice, etc. And then we also use a schedule of reinforcers that we then reinforce the child with that we give the parents to take home. So basically what we're saying here is we thought, I don't know if we're right or not, I'll come back to this in a moment, but we thought we might be wrong. Of course we might be wrong. We're always possibly wrong. But my main point is that we thought they needed more than just the 1-3 hours. And we wanted to come back and give them these booster sessions to make sure that the treatment was really, because 3 hours isn't a lot of time. When you're thinking of many of these kids have had phobias for years. Well, they have to, as you know, from DSM, at least 6 months. But at least in many of our kids, it's like 2, 3, 4 years, depending on their age, of course. So we thought that would be necessary to do that. Now, a multiple baseline design study is also what's called a single case study. So you guys can do this. I do some of this in my own clinical practice. You have people who come in. Here they have an ID, a number, their age, their IQ, because we wanted to be able to describe our sample. The treated phobia. Look at the phobias for a moment. Insects, storms, dark, chewing gum. That's a little bit different. Insects, heights, insects, and dark. So almost all of those for 8 of the 9 children, it's phobias that other kids have too. Now, we've never met a non-ASD child who's had a phobia of chewing gum. In another study, we treated a child phobia with ASD of buttons, had a button phobia. And actually had my sport coat on, and he was wearing that during treatment because there are buttons on it. And we were trying to get him to be exposed to buttons. And we had different colors of buttons, and he had to identify the colors, and I had to put them in stacks of yellow buttons and green buttons, and had to touch them to do that. But he had never worn clothes with any button on it or any zipper on it since, parents said, since he was an infant. And he was, I think, 11 years old at the time. And also, he would only wear like a sweatsuit during the day and to school, and to the parents' chagrin, to the parents' real chagrin, to church. And they were very religious people, and they would take their family to church, but he would always wear this outfit. Never anything with like a shirt that would button up or pants that would button or a coat or anything like that. Never, never, never. He just didn't do that, you see. And so we had them come back a year later in the 40s, and he comes in just so proudly smiling, a grin from ear to ear with a little sport coat on. He was dancing and prancing that he was doing so well with his buttons. But you don't think of that, that yes, it can happen. That it was just this thing that affected the whole family, but it was this phobia. It used to be called simple phobia, by the way, which I think, and I was very much opposed to that. It's not called specific phobia, but very, very different. Over on the right-hand side, you can see that they met diagnosis. They also met diagnostic criteria for autism, and they really were relatively high on that level, from moderate evidence to high evidence of autism. On this ADOS, as it's called, you can have different levels of that. Now, these means and stuff won't be of much import to you because of variables of the parent rating, the child rating, and a parent fear rating. Well, the main point, as you can see by the P levels, or in the 1, 2, 3, 4, fifth column, 0.006, 0.010, 0.019, they all change significantly over time. And what's called the effect size, over on the far right side, 0.58, 0.53, 0.45. Down below, I have included here the clinician severity rating, the effect size. Greater than 10 is a small effect. If it's greater than 30, it's what's called a medium effect. And if it's above 50, it's called a large effect. So you see, we have here evidence that these are having large effect sizes to moderately high effect sizes. 0.5 or above, 0.45 didn't quite make it, but it was a medium effect size approaching the large effect size. I hope you see that and understand what I'm trying to say. Now, here's our single case design. Again, this may not be very meaningful for you, but over on the top graph, there are 4 subjects. The middle graph, to the right, I should say, there are 3, and the bottom, there are 2. These are just a different baseline. So they have different baselines. Look at the one at the bottom, for example. The child had 5 baselines after 5 weeks when they came in, and we got their rating. Didn't change. And in one case, it went up a little bit. And the highest score that can be is an 8. 0 to 8 was the range. And then subjects 3 and 9, when they come back after treatment, they're down to a 5 or a 4. Those up on top are down to a 1 or a 2. So we want to get them below that level of 4. That's our magic number here. And you can see that for many of them, they do that. Now, currently, and I'm going to stop here in just a moment, I promise, so we have a little time to see if there are questions and comments. We're now doing a randomized treatment control trial funded by the Organism for Autism Research, in which we're trying to recruit a relatively low number of people, 30 youth with autism spectrum between 7 and 14 years of age, because that's where most of our other data has been. But we have done with 2 to 4-year-olds and 18-year-olds, et cetera. We're going to put 15 in our augmented standard and 15 in our augmented OST. So the one I showed you on the right-hand side before is going to be the one condition. Do we need to do all that? Or can we get good effects with just what we typically do? Not have them come back in clinic sessions, or just have them have the phone calls for 15 minutes rather than an hour-long booster. And that's important, you see, in terms of travel, in terms of commitment, in terms of cost, efficiency, et cetera. So by the way, we are showing that our treatments are very cost efficient and very effective. And then we greater parent involvement, the weekly booster sessions, home-based, we've said that already, and we're measuring all these different things down at the bottom. So this is a study that we're currently underway. And if the virus ever lifts its mighty influence over all of us, we'd love to have you folks refer people up to us. We're in the midst of that project currently that's ongoing. Now, where do we go from here? One of my favorite books is Alice's Adventures in Wonderland. Alice says, would you tell me, please, which way I have to go from here? And the Cheshire Cat, in its indomitable way, says, that depends a good deal on where you want to get to. Pretty nice, huh? That's exactly right. Where do we want to go? For those of you who don't follow Alice's Adventures in Wonderland, how about Yogi Berra? Maybe you do that. Yogi is known to have said, if you don't know where you're going, you'll end up somewhere else. Isn't that true? If you don't know where you're going. I actually had this happen to me, well, no, not really. In March, I think it was, I was over in Roanoke, and Blacksburg is a little bit smaller. I was looking for a certain restaurant, I couldn't find it. I didn't know where I was going. I wasn't using GPS. I ended up somewhere else, and I did. It took much longer to get there. But the main point here is we need to know where we want to go. Now, here are some things that can happen, and we're doing those with an asterisk. We're doing those here and have done them in other countries too. The self-help biblio I've already talked about. Virtual reality we're attempting. We're doing attention bias modification training, that's a computerized program. We've done a drug supplement intervention. We use DCS, D-cycloserine, which is known to be a memory enhancing drug. And we're hoping that will lead to better effects. We're also doing personalized approach. We're using these, what are now called smart designs. So we're doing a lot of different trials looking at these things. Well, my concluding comments will be that evidence-based practice needs to become the preferred option. And we need to look at this very, very carefully. And that if we can do this idiographic treatment approach, idiographic meaning individually tailored, one size does not fit all. That's exactly what we have done, and I would submit that many medical professions have done the same thing too. Over the years, it's changing, personalized medicine, and that's what we're talking about here is more of a personalized approach. We need to look at some of these features to look at that. Well, I conclude with a quote by Mark Twain, a man, and then I inserted or a woman, who carries a cat by the tail learns something he or she can learn in no other way. Now, I think that's exactly what I've been trying to share with you today, is that we have been trying to carry psychotherapy by the tail and to turn it around, turn it upside down, and see if we can learn something about it and see if we can produce it as well. This, by the way, is one of my grandchildren, Addison, a little book that I've written about her, Addie and that rambunctious dog, for a self-help treatment. But this is it. So I think what I want to conclude with is that we can do more in these different ways. Now, I'm sorry I've rushed through this a bit, but I'm going to conclude with these 3 multiple choice questions. So the first one, I guess you take these. The phobic and anxiety disorders can be caused by genetic factors, temperament, direct and indirect learning experiences, all the above. You get to choose one of those 4 options. Not guess, but choose. Number 2, effective CBT treatments include psychoeducation plus play therapy, psychoeducation plus cognitive challenges, modeling, exposure, and reinforcement, psychoeducation plus a dream interpretation, none of the above. You get to decide which one of those is the correct response. After I go through the third, I'll come back and give you the correct answers, just in case you're wondering. These are pretty simple questions. So brief intensive CBT treatments for phobic and anxiety disorders in youth are not as effective, are inefficient and costly, are efficient, effective, and may become the treatments of the future, are not evidence-based, and frequently cause other problems in youth. Again, select A, B, C, or D. Phobic and anxiety disorders can be caused by all of the above. That's this whole point about multiple causation. Effective CBT treatments does not include play therapy, does not include dream interpretation. It does include cognitive challenges, modeling, exposure, and reinforcement. Those are the ingredients of CBT. Brief intensive CBT treatments are C, efficient, effective, and may become the treatments of the future. I've just written an article with a colleague from State University of New York, Stony Brook, in which we're putting this out, where we're trying to say that we've got to turn our field around. And what we're learning with the coronavirus, by the way, is that we do not have to do these very long, elaborate treatments. We can do briefer treatments. Even this 15, 20 minutes, 30 minutes, half hour, we can get a lot done in that.
Dr. O, there's a couple of questions. Someone wanted to know, is bullying in school related to the development of social phobias?
Brilliant question, and the answer is absolutely. We have just completed a trial on social phobia, attribution bias modification training. And one of the causes for social anxiety, social phobia, it's called social anxiety these days now in DSM. But yes, that is oftentimes, I shouldn't say oftentimes, that's not true. Let me reverse that comment. It is sometimes resulting from bullying, and cyberbullying too, by the way, is even more common, and which people are really there. One of the studies we're doing now is following up some socially anxious adolescents and seeing how they're handling the virus and the COVID-19 and this being at home. And actually they're, on the one hand, really loving it because they aren't being exposed to the bullying and all the stuff at school or in the neighborhood. Kinds of things like misinterpretation of cues that are going on, and just a host of things, modeling and reinforcement, that all result in social anxiety. And some of them classical condition, others more modeling or reinforced. Yes, very good question. Yes, thank you very much. It can certainly result in that. And we really need to do more about that.
And then we had a question that says, the identification of specific phobias may not always be present, say generalized anxiety. Is this common?
That's another excellent question. The answer is absolutely yes. In fact, there's a recent study that I could send over to people if they want to see it on generalized anxiety disorder and specific phobias. In fact, it's quite common. And that's why I say that you have to look for these things because, you might think it's just this generalized anxiety, and indeed that can be the case, but they also might have specific phobias. By the way, in one of our studies, we actually show this, that we treat the specific phobia, with one session, and we look at, does it affect generalized anxiety? And it did. It did. Generalized anxiety is going down. Why? Well, what we wrote and said and think is that it went down because the kids were becoming more self-efficacy. That point I made about Bandura's work before, where they said, I can do this, and they transferred or generalized that information to their other problems, and they could learn to overcome them too. So self-efficacy. When you're working with kids and families, if you can help them say, I can do it, I can do it, I am the master of my fate, my ship, my whatever. That's not always possible. You can get them to think along those lines. That's what you want to do. And I think that can help. But yes, there are, by the way, you can't see these here, but DSM has put out some sheets. If you just go into the DSM website, actually the American Psychiatric Association website, and they have these DSM sheets that are like screeners for anxiety that you can give to parents and for children between 11 and 17 at least. And I strongly encourage you to look at that because we find when, like with ASD, we never thought anxiety would be as high as 60%, but it was because we looked for it. And that's also true of these other things that if you look at social anxiety, again, they too can have specific phobias. In fact, in the major clinical trial, what's called the John Walkup trial, the psychiatrist up in the Massachusetts area, they had something like 70% of the case, no, more than 80% of the people were comorbid with more than one disorder, social, specific, generalized, panic, separation, etc. Very common to have those occur. Great questions, yeah.
And then there's a question that says, is there a role for psychotherapy in the inpatient hospital setting?
Oh, there's a tremendous role. Yes, that's a great question. I would say yes, most assuredly. And I'm not sure if any of you, some of our students work over at Carilion in the inpatient setting for part of what we call their externship. And clearly there's a need for it. And there's a need for both group intervention and individual therapy. Very much so, yes. Of course, that's on a psychiatric unit, but on more hospital units, or medical units, I should say. Think of it for a moment. If you've been in a fire and burned, I don't know, you have to look at what's going on, or you have cancer, some cancer patients, yeah, they have psychological problems. Of course they do. How could we think they wouldn't? I had a good friend literally just 2 days ago from Emory University die of pancreatic cancer, 59 years old. And he's been dealing with anxiety with that for the last 7 years. And it was just tremendous. His kids also developed anxiety about they might develop cancer. But yeah, so there's a very important role for it. And I think we just need to listen. We need to listen to the people and see what they have to say and hear them out. And many of them will then relate to you. And they can use some of these beneficial cognitive behavioral interventions that can be done in a brief way. Not just the one session treatment. I'm not trying to sell you on that so much as brief intensive interventions can be very helpful.
And we had a question, do you have recommendations to prevent negative psychological effects with the use of social media?
Wow, that's a great question. It's a loaded question, isn't it? Yeah, prevent social media from occurring would be the best response I could give. That really is again, extremely important question. The main thing that we have been doing with parents is to try to limit the amount of social media that kids are using. And there are some practical guidelines that I think the American Pediatric Association came out with, I believe, if I remember right. I know they're out there that you try to limit the amount of time on the social media platform. And that can be done. It's the parent is still the parent. I'm not saying you have to be autocratic, but you talk about these things with your children. We have 2 daughters, we have grandkids, and we try to work with this stuff with them in terms of how to do that. But yes, you try to limit the amount of exposure to it. Try to limit the various sites they're on. There's some really trashy stuff, as you know, out there. And it's hard, though, because many families or 2-parent households are working, both parents. Kids are home alone now sometimes. It's even harder these days than it was. And how do you do that? There's no easy answer. First of all, it's just so pervasive. Well, I think we need to limit it. We need to limit access to it if we can't limit the amount of it going on, which we can't do. That's out of our hands. But we can limit access to it, I think, and that's the number one thing. And to try to guide them onto certain kinds of things. There's a beautiful program, by the way, that Mike Friedlander, I don't know how many of you know him, but over at VT, what used to be called CRI, the medical school, the Fralin Medical Institute there. He gave access to all of us, and I can send you that link if you want, about a really great musical for basically 7 to 11-year-olds. That's really something on the internet, but it's not all this garbage that's going on. So yeah, I mean, there are other programs. There are lots of different. There's a program or a group called Mind Institute that puts out little recommendations that parents can use. So yeah, there's quite a bit of stuff out there, but it's really, really hard. And we found that the use of social media has increased in the last 6 months during the virus, and that we're trying to link it. We don't think it's yet causal, but it's certainly going to be associated with. It's like smoking used to be with cancer. It wasn't causal at one time. It was just related to associated. But this is having an association that may well be causal. That's yet to be determined. Thank you. So allow me to conclude by thanking everyone and wishing you to have a good day.